If you're listening to this podcast on YouTube, for a better experience, switch to the video version. The link is in the episode description. Hello and welcome, I'm Fernando, a GP in the UK. Today we're reviewing the NICE guideline on the menopause, always focusing on what is relevant in primary care only. Today we will focus on symptom management and treatment risks. In the last episode, we covered diagnosis and treatment choices, and in future episodes we will cover the other sections of the guideline. Right, let's jump into it. We will start by covering the management of menopausal symptoms in people aged 40 and over. This is because for people under 40, we should follow the separate NICE guideline on premature ovarian insufficiency. Let's look at the various possible symptoms one by one. For vasomotor symptoms such as hot flashes and sweats, NICE says we should offer HRT. Menopause-specific CBT can also be considered and used in addition to or instead of HRT. Fesoniletant is also recommended as an option when HRT is unsuitable. Fesolinetant is not HRT, it works through receptor pathways involved in temperature regulation. Although recommended as an option, it may well be specialist-initiated only, depending on local prescribing guidance. NICE says we should not routinely offer SSRIs, SNRIs or clonidine as first-line treatment for vasomotor symptoms alone. Now let's look at genitourinary symptoms. For symptoms with no history of breast cancer, we should offer vaginal estrogen, including in people who are already using systemic HRT. We should explain that serious adverse effects are very rare and that symptoms often return when vaginal estrogen is stopped. But treatment can be restarted if necessary. Vaginal estrogen is absorbed locally and a minimal amount is absorbed systemically, which is unlikely to have a significant effect throughout the body. Types of vaginal estrogen include creams, gels, vaginal tablets, pessaries or rings. They can be used alone or with non-hormonal moisturizers or lubricants. If vaginal estrogen is contraindicated or the person prefers not to use it, we should then just consider non-hormonal vaginal moisturizers or lubricants. If vaginal estrogen, moisturizers or lubricants have not worked, we should consider vaginal prasterone or oral ospemifene. These medicines are not started routinely in primary care, and the use will depend on local formulary and prescribing guidance. For people with genitourinary symptoms, an overactive bladder, or recurrent urinary tract infections, NICE signposts their specific guidance in those areas. For people with a personal history of breast cancer and genitourinary symptoms, we should initially only offer non-hormonal moisturizers or lubricants. If symptoms continue despite this, vaginal estrogen can be considered and used with a non-hormonal moisturizer or lubricant. However, this is an off-label use, so we should seek specialist advice before initiating them, particularly if the patient is taking aromatase inhibitors as adjuvant treatment for breast cancer. Patients should be made aware that it is unknown whether vaginal estrogen affects the risk of breast cancer recurrence, given that only a minimal amount is absorbed systemically. For people with estrogen receptor negative breast cancer, vaginal estrogen is unlikely to increase the risk of recurrence. On the other hand, for people with estrogen receptor positive breast cancer, NICE says the risk of recurrence could potentially increase. However, adjuvant treatments such as tamoxifen would reduce any such potential impact. But as we said, this is likely to be a specialist decision. For depressive symptoms associated with menopause, NICE says we can consider HRT if the symptoms do not meet the criteria for depression and started around the same time as other menopausal symptoms. CBT can also be considered for depressive symptoms which are associated with vasomotor symptoms. However, if someone has depression, we should also follow the NICE guideline on depression. For sleep problems such as nighttime awakening associated with vasomotor symptoms, menopause-specific CBT can be considered, either alone or alongside other options, including HRT. For low sexual desire associated with menopause, NICE says we can consider testosterone supplementation if HRT alone is not effective. However, in the UK, testosterone use for this indication is off-label and prescribing depends on local formulary guidance. So as GPs, we should consider specialist advice, although ongoing prescribing may sometimes continue in primary care following specialist initiation. Before offering treatment for the menopause, we should consider referral if there are contraindications to HRT or if there is uncertainty about the most suitable option. For people with type 2 diabetes, we can consider HRT after taking comorbidities into account, and specialist advice can be sought if needed. For people at increased risk of venous thromboembolism, we should consider transdermal rather than oral HRT, and this includes people with a BMI over 30. For people at high risk of venous thromboembolism, for example those with a strong family history of thrombophilia, we should also refer to a hematologist before starting HRT. For people with a personal history of coronary heart disease or stroke, HRT should only be offered by a menopause specialist. For people with a history of breast cancer or a high risk of breast cancer, NICE says we should also refer to a menopause specialist. There is separate specific guidance for people at high risk of ovarian cancer, so we will not cover it here. For people who are likely to experience menopause because of medical or surgical treatment, NICE says they should be able to discuss fertility with a fertility specialist. Trans men and those who have taken gender-affirming hormone therapy in the past should also be referred to a menopause specialist. So that is it, a review of a section of the NICE guideline on the menopause. We have come to the end of this episode. Remember that this is not medical advice, but only my summary and my interpretation of the guidelines. You must always use your clinical judgment. Thank you for listening and goodbye.